Thank you for being here. We're going to have 4 different speakers this morning that are going to cover inflammatory bowel disease. My name's Tim Allers. I'm the Vice President of Marketing and Business Development at Mercy. I'm pleased to be here with you this morning. I do want to share with you that our mission at Mercy is to heal and comfort the sick and work to improve the health of the community through the Spirit of Jesus Christ and the Sisters of Mercy. And one of the ways in which we attempt to do that is by providing educational seminars so that you can come and listen to our experts and dialogue with our experts and learn more about specific diseases, conditions, so you can be an active participant in your own health care. One other opportunity I want to offer you before we get started is we've been for quite a while doing some personal wellness profiles for individuals that are interested. What it is a questionnaire you fill out if you're interested, and you could come in and get a free screening and do some lab work if you're interested, and we'll share a report with you on kind of the current status of your own health if you're interested in something like that. The packet looks like this. If you want to take it with you when you leave today, it's free and it's voluntary. It's at your interest. So with that, I'd like to get started. I do want to thank Iowa City Channel 4 for being here today and for recording our program. And in the future, the program will be viewed on Channel 4. So thank you. What we're going to do is have 2 speakers, and then we're going to do about a 10-minute break, and then finish up with the last 2 speakers. So as the first 2 speakers speak, when they finish up, they'll take questions, and then we'll do our break. So please jot down your questions as we go. Our first speaker is Dr. Vivek Mittal. For those of you that don't know him, he's a gastroenterologist who joined our medical staff in 2011. He's a member of the medical practice here that we call Mercy Gastroenterology, and he's board certified in internal medicine and gastroenterology. I'd like to please welcome Dr. Vivek Mittal.
Thank you, Tim, and thank you, everyone, for being here. So I'm going to be talking about inflammatory bowel disease. First of all, some people might be confused about, is it same as irritable bowel syndrome? So it's very different from irritable bowel syndrome, which is IBS. So just in case, just before I start. So basically, IBD, or inflammatory bowel disease, is 2 types, ulcerative colitis and Crohn's disease. So talking about inflammatory bowel disease, there's 2 major types. Crohn's disease, the incidence is roughly, incidence meaning how many new people develop this disease, is 5 every 100,000, and approximately 100 people in 100,000 have this disease. That means prevalence. Ulcerative colitis, which involves mostly the colon, is roughly double the number. So 10 every 100,000 people develop, 10 out of every 100,000 develop this disease, and in 100,000 population, 200 people have this disease. So what causes this disease? So etiology is unclear. We don't really know. Lots of theories, probably thousands of papers about it. So possibly combination of genetics. So you can see people, their family have this disease and they tend to develop this disease, and environmental factors. That's, again, a big lecture on that. Some people say because we are too clean, we don't get involved with much of microorganisms, we are very sterile, so that tends to develop people when they grow up, when they encounter these bugs, they tend to develop this disease. But it's still unclear, it's still kind of up in the air, lots of research going on. What's the difference between Crohn's disease and ulcerative colitis? Though they are very similar, both of the diseases are autoimmune diseases. But Crohn's disease it affects any part of the GI tract from the mouth up to the anus. And it's transmural, meaning the whole wall of the gut is involved, not just the superficial layer, but up to the deep part of the layer. What about ulcerative colitis? Ulcerative colitis is strictly in the colon. Sometimes people can get backwash ileitis, which means the last part of the small intestine gets involved, but strictly it's the colon disease. I'll start with the Crohn's disease. So what's the distribution? Primarily, the disease involves this area, which is where the small intestine connects to the colon, called ileocecal valve. Half of the people have this disease. One third of the people have only colon involvement or the last part of the small intestine. Otherwise, you can, as I mentioned before, any part of the gut can be involved. Now, coming to the symptoms, how do you know if somebody has Crohn's disease? First of all, I didn't mention here, but it's mostly population is younger people in the teen years, second decade or third decade. So, but it can affect any population. I have patients in their 30s, 40s, 50s, 60s who were diagnosed with this disease for the first time. So the symptoms are the pain in the right lower side of the abdomen and diarrhea. It's not continuous. The diarrhea doesn't happen every day. It can come and go, but it's persistent, doesn't leave you. So sometimes you can have bloody stools, which is there's diarrhea mixed with blood. Also, there can be low-grade fever, very low, 99, 99.5, and weight loss due to multiple reasons. If there's a severe fever, if there's high-grade fever and severe pain, it's usually indicative of a complication, which I'll go on later, like abscess or fistula, something which is worse than just the Crohn's disease. What about the signs? Signs are what physician or healthcare provider notices when there's an examination. So tenderness in the right side, usually on the right lower side, because as I mentioned, the area of the gut which is involved is the connection between the small bowel and the colon, which is usually on the right lower side. There can be even mass because of all the inflammation. Sometimes on rectal examination, a mass can be felt. Abdomen can be distended because of obstruction and blockage and enlargement of the gut. And if there's severe pain, unbearable pain, usually there's rupture of the intestine. What about the labs, the blood work? What does it show? Well, it's very non-specific. Things we look for is what's called ESR, which is sedimentation rate. Also, it's usually elevated because it means there's an inflammation going on, meaning somebody is having these products in their blood, which makes this ESR go up. If the disease is in remission, then this can be normal. This is a test we sometimes use how patient is doing. If the medicines are working, if the ESR is normal, then usually their disease is in remission. Low hemoglobin or anemia, multiple reasons. It could be because the iron is low, either because of bleeding or decreased absorption, because it's a chronic disease, so the bone marrow doesn't produce a lot of blood, and also vitamin B12, which is absorbed in the last part of the intestine, can be involved. If there's high white count, high platelet count, that's a marker for inflammation. That can be high as well. Also, protein is not involved, and protein is also spilled into the stool, so the albumin level, which is the protein level in the blood, can also be low. So looking at some pictures. These are some pictures of barium enema, which is or barium swallow. So small bowel follow through, which is you drink barium, which is the white, really nasty tasting substance. I'm sure a lot of you know about it, which goes through the gut and coats the gut, and pictures are taken. Sometimes it's pushed through the rectum. Actually, that's much worse. And it coats the gut. This is on the left side. This is the normal-looking small intestine with folds. And here you can see this almost like a corkscrew pattern. This is a small intestine which has been affected. That diameter is smaller. There are no folds in it. Same way over here. This is the normal looking small intestine with nice distension, folds with these black lines, versus over here, the Crohn's disease gut is affected with very narrowed diameter. So it's not coating the gut. This is an X-ray of a patient with Crohn's disease. Here, all these black round structures are air levels. So there's an obstruction going on, and this is causing all the fluid to build up. And because of the fluid, on top of it is the air, and that's why it looks black in nature. This is suggestive of Crohn's disease, not diagnostic. Abdominal CT, how good is it? Not that good, because looking inside the gut is not that easy with CT scan. But it's good for looking at complications like abscesses, which is happening outside the gut, fistula, which is a communication between the gut and outside. There's a study which we do for last few years, which is called capsule endoscopy. That's a small pill. There's a video recorder in the pill, and it's swallowed. There are video recorders on both sides of the pill, and it goes through the gut, and while it's going, it's taking pictures while it goes down. There's also a wireless transmitter, which patient wears as a belt and visualizes the small ball. Usually, just the pill is usually flushed away. We don't ask you to collect the pill. So here, this is just how the image is done. This is the enlarged view of the capsule. It's the size of a pill, like regular pill, and there's one camera on this side and one camera on this side, and there's a transmitter worn over here, and as it goes down, pictures are taken, and we can actually look at those pictures on a computer and assess. What other studies can we do? Well, as I said, barium enema and colonoscopy are also used. Colonoscopy is actually preferable over barium enema because, one, we can look directly on the gut, and second, biopsies can be taken. Our pathologist can look at those biopsies and help us diagnose it. I'll show you some images about that. Barium enema can evaluate fistulas and stricture when there can be leakage of the contrast happening through those areas. So fistula is an opening in the gut which is communicating with either another part of the gut, bladder, or outside. That's the fistula. Stricture is when there's complete narrowing and almost complete obstruction of the lumen. Both can also provide evaluation of the last part of the gut, where the last part of the small intestine, where it's connected to the colon. So classic findings on Crohn's disease. Well, one is skip lesions, meaning normal part of the small intestine or large intestine, followed by diseased, again normal, then diseased. This is different from ulcerative colitis, which I'll talk later, where everything is continuously involved. Cobblestoning, little bumps as if you're walking on a cobblestone floor. It can be due to mucosal fissures. Also strictures, which almost look like a string sign, can be there. Fistulas, which, as I talked about, communication with the outside. And tiny ulcers, which are painful. Aphthous ulcers can be seen. These are some images of the patients with Crohn's disease. This condition is called angular cheilitis. It's a non-specific finding. At the angles of the mouth, there can be little fissures, shown here with the arrow. In fact, it can happen in a lot of diseases under stressful conditions, but very common in Crohn's disease. These are the aphthous ulcers. Again, this happens in stress, these tiny ulcers in the mouth, which a lot of people have experienced under stressful condition, exam time or in journal. Here you can see another ulcer in the lower lip. This is a fissure, anal fissure, which can be seen. Actually, somebody can present as an anal fissure, and they end up having Crohn's disease on further interviewing. These are colonoscopy images of the small intestine. Here, the mucosa is very flat. These whitish areas are the ulcers. Again, in this image, the colonoscopy image looking at the small intestine, all this area are ulcers. Again, this is cobblestoning. These little white areas are bumps in the small intestine because of inflammation and Crohn's disease. Again, this is the small lumen which has been left over with the stricture. Otherwise, it's supposed to be big opening. This is a surgical specimen of a small intestine. Here, this is the normal part of the gut where it looks normal, and here the fat is almost creeping up over here because of the inflammation. This is the opened up specimen of the small intestine in Crohn's disease. These long areas, this is a strictured area as it's narrowed, and these are all the strictures. So we see this, these kind of images. Again, this is a connection of the colon with the small intestine, and here, this is very narrowed up, showing inflamed ileum, which is the intestine, suggestive of Crohn's disease. These are the biopsies which we obtain from patients and send it to our pathologist. This part of the slide represents the lumen of the gut, and this part is underneath. Here you can see a lot of blue area, meaning a lot of inflammation. How about differential diagnosis? What other diseases can look like Crohn's disease? Well, if there's acute appendicitis, as we all know, right side lower abdominal pain usually is appendicitis, so that has to be ruled out. Ectopic pregnancy in females, abscesses, or infections. Also, people who have diverticulosis, if they get their diverticulitis attack in the right side, meaning cecal diverticulitis. Also, certain infections which tend to favor that part of the gut, Yersinia. Also, infections in immunocompromised patients who had transplant or on immunosuppressant drugs like CMV. Cancers rarely can present like that. How about if it's only in the colon? Then infections have to be ruled out. For example, Salmonella, Shigella, Campylobacter, these are the infections. Amoeba, which is a parasite, along with viral infections. Other diseases which are non-infections are ulcerative colitis, which have to be ruled out, along with radiation colitis and low blood supply colitis. So I talked a little bit about complications. So what are the complications we see? One is fistula, where there's an opening in the gut, which over here it communicates with the skin. So stool, rather than coming from the normal passage, can also pass through in a different opening called the fistula. It happens in up to 40% of the patients. Also, fistula can develop between one part of the gut and the second part of the gut, called enteroenteric fistula. Also, fistula can happen between the gut and the bladder, which can lead actually to infections because stool is mixing with the urine, and also air can be passed in the urine. Also, over here, as mentioned, the fistula between skin and the gut. Other complications, there can be perforation of the gut, meaning just spillage of stool in the belly, abscess formation, little pockets of pus. Also, strictures, which is because of inflammation, there's scarring, and that leads to a stricture. In fact, the gut can be completely closed, called small bowel obstruction. Also, a lot of nutritional deficiencies, for example, a lot of vitamins and minerals, and especially fat-soluble vitamins, because those are absorbed in the last part of the gut, which is usually involved in this disease. There's some talk about colon cancer, and there is small bowel adenocarcinoma, which is seen in this condition. So I'll switch gears to ulcerative colitis. So again, talking about the symptoms, that in ulcerative colitis, the symptoms are a little bit different. It's more like bloody diarrhea or just diarrhea, mucus diarrhea for a long period of time. Could be weeks to months. In fact, there's a study which says almost takes 6 to 8 months to disease to start and diagnosis. Crampy abdominal pain, usually on the left lower side instead of right lower sides in Crohn's disease. Tenesmus, there's patient feels like needing to go to the bowel, have a bowel movement after going, feel like going back again. The reason being because there's inflammation in the rectum and it seems like there's stool in there, but there's nothing. It's painful usually. It's called tenesmus. Fevers, weight loss are possible. And up to 1/4 of the patients have in manifestations which are outside the gut, meaning, for example, eyes or joints, areas like that. How about the signs which are felt when you're seen by a healthcare provider? Tenderness in the left lower abdomen, because that's where usually colitis happens, in the last part of the gut, which is on the left lower side. It can be mild or it can be pretty severe. Patients who are very sick, which is called toxic megacolon, meaning the gut usually swells up to 10 times the size. There can be fevers, tachycardia, low blood pressure, which are hallmarks of very severe disease, and these patients are usually hospitalized and treated. What about the lab findings? Very non-specific, just the same as Crohn's disease. Usually ESR can be elevated in active disease, low blood counts, low hemoglobin, also elevated white count and platelet counts, thrombocytosis, which are acute phase reactants. We need to make sure the patient does not have infection, especially nowadays with a lot of C. diff. We hear about it a lot. We need to make sure patient does not have C. diff. In fact, patients with ulcerative colitis can have sticky gut, and they tend to get C. diff a lot more often than average population. How about imaging and studies? Well, the disease affects the rectum, so it starts from below and extends upwards. So even doing a sigmoidoscopy, for which we don't give any preparation and we just can have the patient do it while awake, can be done, but we prefer to do a colonoscopy so that we can have a good look at whole colon. Biopsies can be performed and sent to the pathologist, who can help us ascertain what's going on there. As discussed earlier, barium enema, barium follow-through can be done, which can show mucosal changes, but tissue cannot be obtained, so we prefer doing colonoscopy, and it's much more easier. The classic finding on barium study is a lead pipe colon, which does not get distended. It stays stiff and has lost all its folds. These are the colonoscopy images showing how the disease evolves. On the left upper side is a colonoscopy image of a colon in a patient which is normal. Here you can see pale mucosa, red blood vessels, which is a very normal looking colon. Here there's mild ulcerative colitis. You can still see the blood vessels, but you can see the mucosa is much more red, which we call erythema, and there is a lot more redness around it. Here the moderate colitis with ulcers. There's some thickness in the wall, and here it's a severe. These white areas are the ulcers. This red is active bleeding going on. This is severe ulcerative colitis, and they are treated differently. Few other images. These are ulcers in the colon. Again, this is exudate. This white area is pus, which is coming from these ulcers in the colon. Again, another image of pus and ulcers in the colon. These areas, although they look like polyps, but they are what we call pseudopolyps, which are seen in ulcerative colitis due to inflammation, due to swelling in the lining. Here, boggy folds, which are swollen up, almost blocking the lumen, are seen in ulcerative colitis. This is a close-up of a pseudopolyp looking close by. This does not have a cancer potential, but we see this as if because of the swelling. This is a removed specimen of a colon. All these areas, these little dark areas, are pseudopolyps, and whole colon is involved. Looks like a lead pipe instead of a nice, healthy-looking colon. This is a microscopic image of the biopsies. Here, these round areas are the glands, which are seen in the colon. They are all full of these inflammatory cells, which go and secrete all these toxins. Again, ulcers, breakage of the cells is seen in biopsies on ulcerative colitis. Another biopsy image here, all these darks, this is the surface of the colon. All these dark cells are the inflammatory cells wreaking damage in there. So ulcerative colitis is normal. There's a normal colon because of certain reason, be it autoimmune disease, be it certain reason, all these inflammatory cells, which basically help us fight against the diseases, come in and they feel the gut is under attack and they try to attack it back. And the gut tends to be like an innocent bystander and gets damaged in there, although there is nothing going on. So how about differential diagnosis? Again, infections with various organisms, or Crohn's disease, ischemic colitis, radiation colitis in immunocompromised host who's on steroids or had a transplant, CMV, HSV, all these infections can cause it. Talking about the complications. Well, the complications include toxic megacolon. The colon can become much bigger in size, and mortality can be up to 50%. perforation of the colon can happen because of increased swelling, increased pressure, and ultimately rupture, as if you can blow a balloon up to a certain size and then it ruptures. There's increased risk of cancer in people, so especially goes through dysplasia. Over time, there can be a increased risk of cancer. So after 20 years, the risk of cancer is almost 5 to 13%, and after 30 years, the risk is almost 1/3 of the patients develop colon cancer. As mentioned, so cancer is a big complication of ulcerative colitis. In usual colon, the cancer develops from polyps, but in ulcerative colitis, the polyps usually don't develop cancer. Those are pseudopolyps. It can happen from a flat surface. So when we do colonoscopies, we actually tend to do hundreds of biopsies to make sure we are not missing any area. So every 5 to 10 centimeters, we do multiple biopsies to make sure we are not missing anything. And if we find early cancer or progress towards cancer, then surgery is required. How about the prognosis? Well, it depends upon the nature of the disease, how bad the disease is. In one study, colectomy, meaning complete removal of the colon, was seen in almost 1/4 of the patients at 10 years and 1/3 of the patients at 25 years. Now, with better treatments, this actually rate is going down. The rate of colectomy means removal of the whole colon because of the disease, is much higher when there's whole colon involvement. So colitis can involve only the last part of the colon or the whole colon. People who have only the rectum involvement or just the distal part of the colon involvement, they actually can do just fine. And the silver lining on the colectomy is it's actually 100% curative, meaning if we take out the whole colon, there's no area to have the disease. And with the newer surgical techniques, people actually can have a pouch created so that they don't wear a bag. It's just like a normal, healthy lifestyle. So summary, ulcerative colitis versus Crohn's disease. Ulcerative colitis does not have any perianal disease, any fistulas, abscesses, or stricture. The reason being it's only on the surface of the gut, versus in Crohn's, perianal disease, fistulas, abscesses, and strictures can develop. On colonoscopy, rectum is always involved in the ulcerative colitis. In fact, when I do colonoscopies, when I see rectum is normal, I usually say there's no ulcerative colitis going on. And pattern is usually continuous from rectum, it goes all the way up rather than skip areas, which is seen in Crohn's disease. On small bowel involvement, it's rare. Usually it's backwash ileitis, meaning little involvement of the distal part of the small intestine. But in Crohn's disease, it's very commonly involved, be it isolated, small bowel, or along with colon. On biopsies, when our pathologists look at it, the involvement is just the mucosa in ulcerative colitis versus the whole wall of the gut in Crohn's disease. Also, there's something called granulomas, little nodules which are seen on biopsies, which are uncommon in ulcerative colitis, where it's hallmark of Crohn's disease. Treatment, I won't talk much about the treatment. I'll leave it to Mike, who'll be talking about it much more in detail. But it starts with 5 ASA drugs, sulfasalazine, which is an old school drug, which is still used sometimes, has a lot of reactions, corticosteroids including prednisone, immunosuppressants like azathioprine, sometimes methotrexate, biologics like infliximab, Humira, Cimzia, especially when there are acute infections going on, antibiotics like ciproflox and Flagyl are given. Probiotics, we don't know much about it. There are a few studies which I believe our dietitian, she will talk about. And then surgical management. Perforation, that's when we have to intervene quickly. Our surgical colleagues get involved. Hemorrhage, if patient is continuously bleeding and needing multiple blood transfusion. Blockage of the small bowel. Abscesses, either it's in the abdomen or in the perianal area. Fistulas, and inflammation, which is unresponsive to therapy. If someone is having 20, 30 bowel movements, not getting better with every kind of medical therapy, we suggest surgical interventions. In fact, almost 80% of the patients with Crohn's disease will need some surgery, be it a small surgery or a big surgery. The goal in Crohn's disease is conserve as much bowel as possible, because a lot of people will need repeat surgery. So you don't want to get rid of the small gut, then food cannot be absorbed. Compared to ulcerative colitis, Crohn's disease surgery is not curative. So that's how it goes. About the treatment, so education, just like we're having this. Support groups, you can go to a website called ccfa.org, and over there are support groups. In fact, there are support groups of the area. Psychological therapy, especially because it's a lifelong chronic disease, not getting depressed is very important. And we should not lose sight of the fact that we are treating patients, not just a disease. So the whole pattern, I have patients who are not worried about the disease, they're more worried about missing work. Things like those should be addressed. I think holding a hand, hugging a shoulder are often more effective than any medicine we can offer. Thank you very much. And I'll take questions in half an hour, maybe, after Mike. Is that okay?
Yeah. Thanks, Dr. Mittal. And as he said, after our next speaker's finished, the two of them will take questions together. Our second speaker is Mike Farley. He's a clinical pharmacist with our Mercy Hospitalist program. I'd like to welcome Mike.
Well, good morning. I'm glad to be here and speaking with you guys today. I am Mike Farley. I work with the hospitals team at Mercy. I also am a faculty member at the University of Iowa. I do want to preface this since I'm talking about a lot of medications that are funded by drug companies, just the fact that I don't have any financial relationships with any of these drug companies, so just want to give that piece of information. So just want to talk a little bit about some of the medications and some of the treatments involved in inflammatory bowel disease. So one thing I did want to address is the goals of treatment. So it isn't necessarily, the dosing and the strategies aren't necessarily the same depending on what point you are in your treatment. So the first thing we really want to do is bring about a remission. So achieving remission, relieving the symptoms, maybe not necessarily an absence, but certainly an improvement, hopefully, in your symptoms, and the things that Dr. Mittal can see when he evaluates you as a physician, and then also when they take a close look and do the scopes and see things internally that they're improving. And then once you've achieved remission or some form of remission, then maintaining that is also, so the strategies often change. Sometimes the doses will actually go down and maybe the monitoring would be less frequent. So I just wanted to point out that those two things are somewhat different in terms of how we go about doing these medications. So there's actually, fortunately, some diseases don't have a lot of treatment options. These disease states are nice in that there really are a number of treatment options that can be used, and so that's really fortunate. I think it's a benefit to use patients and to those maybe that you know. So I'll talk about some of the ways that these are used and the stepwise approach that sometimes is used. But I just want to point out briefly some of the broad categories. There's the and so these are some of the things that Dr. Mittal had mentioned earlier in his slide. The aminosalicylates, antibiotics can be used in certain scenarios. Steroids. I do want to point out too, the steroids that are used in these are not the steroids that you hear about in the news with bodybuilders or cyclists. Those are usually anabolic steroids. These are different. These are called corticosteroids. So unfortunately, if you're looking to improve your inflammatory bowel disease and get ripped, that probably won't happen. But they may help with the first. Then there's immunomodulators. Some of these agents can work in different ways to, as Dr. Mittal mentioned, this is a somewhat autoimmune, an inflammatory process. And so modifying that, actually all these agents in some way or another modify that, but there's some that are more do that in a more aggressive manner. And then the last category, which I'd actually also call immunomodulators, but they're biologic forms. These are some of the newest, I'd say these are some of the fruits of some of the more recent microbiologic some of the more recent biologic work that's been done in terms of seeing some of these agents that come about. They're actually antibodies where they've developed these in a number of really exciting ways, and they can be effective. So they unfortunately do have some side effects, so that's one of the things I'll talk about too. But there are, as you can see, there's a lot of different options. So that's great for you and your physician as you're going about choosing the treatment options that fit you best. As I mentioned, in addition to having benefit for you in terms of improving your symptoms, you always have to weigh that against the risk. So I think it's important when you go into to decide with your physician about the treatment options that are best for you, understanding what is out there. And I think one of the big things you see in a lot of these agents is that when you calm down that inflammatory process, you suppress the immune system to some degree, there is, unfortunately, some infection risk that's often associated with that. And that can vary depending on the agent. Some of the agents have a lot lower risk of that. Some of them have a lot higher risk. So that's something, as a patient, it's good to be aware of. And I think it's definitely kind of those risk-benefit. I think as this figure might say, a lot of times the benefit is much greater than the risk, but it's certainly something to recognize as a patient and be aware of those things that we need to look for in terms of signs and symptoms of infection. So I did want to point this out, too, because there are some different approaches. I kind of, on the previous slide where I showed the different categories, kind of going from the top to the bottom, I'd say that's kind of the classic step-up approach, and that's really the primary approach in ulcerative colitis. In Crohn's disease, sometimes there's two different approaches. They'll sometimes start with the agents at the bottom, the most aggressive approach, what they call the top-down approach, and then go down, versus a step up, starting with less aggressive and going. That's a decision, once again, I think you need to talk about with your doctor, and it really depends on their approach and what they think is the best. But just be aware that those different strategies are out there. So some people may be treated in different ways, depending on if you're talking to support groups or seeing things on the internet. There's definitely different ways to go about it, and studies haven't really shown there's a definitively better option. So it's kind of one of those things that they look at patient factors and what they think was best for you. So I like this slide too because I think it points out that there is a big difference between the two diseases and how people respond to treatment and what's really needed in terms of going through those steps as you go. You can see here on your right is ulcerative colitis, on your left is Crohn's disease. As Dr. Mattal mentioned, the Crohn's disease affects a wider part of the GI tract and also tends to be a little bit more rare. So but you can see that the treatment is actually a little bit different too, that a lot of people with ulcerative colitis actually respond to some of the more, the older, some of the agents without as many potential side effects, the Asacol, the 5-ASA, sulfasalazine, those agents, mesalamine, I'll talk about those in just a second. But you can see a much greater proportion when you compare it to the Crohn's disease respond to just those agents. With the Crohn's disease, you can see you actually have to step up to the steroids, some of the other agents like the biologics or maybe surgery in a greater case. So you can see that the darker boxes actually would signify maybe having to step up to higher levels of treatment, more of those agents. So I just want to point out that there is that distinction in the treatment that's usually out there. So the aminosalicylates, these are one of the older agents, one of the first steps, I'd say, for ulcerative colitis. You can see a lot of patients actually don't have to go beyond this in a lot of cases, so that's fortunate. In Crohn's, it can vary depending on the approach that's taken. And there's really similar effectiveness between different agents, although sometimes the side effect profiles can be a bit different. So that's one thing to look out for, depending on your predisposition to certain conditions, something to discuss with your doctor, which one agent is best for you. The mechanism is interesting. You know, they've learned a lot about these diseases, but some of the medicines, they still don't entirely understand all the ways that they work. They modify the immune system. A lot of them have anti-inflammatory properties. You can see I put a few things on here. There's some of the agents that may affect. Cytokines are inflammatory messengers in the body. Prostaglandins are also very much involved in inflammatory pathways. Actually, one of the drugs you probably use a lot, ibuprofen, has effects on prostaglandins. So there's different drugs that affect these agents. And we really don't understand all of the ways that these work, but in a lot of patients, they're effective. So free radical scavenging, actually, free radicals are sometimes when the different agents in your body are around with oxygen, they can actually kind of throw off these agents that can cause damage to cells. And so that's maybe one of the factors that these affect. So there are multiple agents and release formulations too. So you may see the same drug in different formulations that releases over time or releases at a different part of the colon or something like that. So there's a lot of different things out there in terms of these agents. I did want to just briefly, since I said the side effect profile is a bit different between the two, the older drug, the sulfasalazine, is actually a prodrug and metabolized to the aminosalicylates, so it has a little bit different profile in terms of the side effect. A little bit more of the side effects are present there, but they both have side effects. So depending on how you are and your risks, the physician may choose a different agent depending on your side effect risks. Antibiotics. So we think of antibiotics traditionally. If you have an infection, you take antibiotics. And generally, that's the role for these agents in inflammatory bowel disease. Although some people have looked at taking them on a more frequent basis to see if that's helpful. There hasn't been any bug in particular that's been identified that they're really targeting with these, but they may have some anti-inflammatory properties with them. And then also, if you have a specific infection, so if there's maybe an abscess that they're seeing when they look inside your bowels, whether that be with an imaging study or actually going in with a scope, maybe they want to treat you with a antibiotic. And Flagyl, metronidazole, or ciprofloxacin are some of the agents that really have been used most frequently. Now, there are some other ones certainly that can be used also. Side effects, with the most common ones here, I think of with alcohol, you have to be very careful. Metronidazole actually will cause a strong nausea response with alcohol, so that's something you have to watch out for. And then ciprofloxacin, we have to watch out in patients with heart conditions because it can actually cause some changes in some of your heart rhythms. So the other thing we always want to be thinking about with antibiotics is if we're giving these, maybe the next time if there is a bacterial pathogen involved, it may actually change and become resistant. So that's something we're always concerned about when we're using drugs, antibiotics in particular, that the pathogens don't change. So every time we use them, I think the chance of having a resistant organism goes up a little bit. So we have to be real cautious and use them with a good judgment. Steroids, did talk about this a little bit earlier. They definitely have anti-inflammatory and immune system effects. There's actually the effects, if they're whole body, are a little bit greater than if sometimes they can be more targeted right at the colon. Some of these agents, like budesonide, is one where they can actually, a steroid that they can actually give either rectally or orally, where it can target a particular, just the colon instead of the whole body. When you give it a whole body, you tend to get more of the side effects. That's one thing that is important. Can be really beneficial though, and sometimes these side effects are worth it for the benefit that you get from these agents. So electrolytes is one that we have to watch. We keep an eye on your electrolytes. Those are just some of the agents in your blood. Some people can have some mood changes on steroids. They can either feel, some people are very hyped up and ready to go. Some people actually like it. Some people feel very drained on them, so it can go either way there. You can get swelling and weight gain with these agents that actually does cause that sometimes swollen face. So that's something to be aware of. A lot of times when you stop the agent, it will go away though, so it's not like it's a permanent thing. And bone effects, that's an important one. Patients that are on these agents for a long time, they can actually get a little bit of a degradation of their bones. So it's really important that they maintain a good calcium intake and that we're keeping an eye on that too. So that's something they can check for in your office, whether it be your primary care doctor or someone else, and it's making sure that your bones are maintaining a healthy level and your fracture risk doesn't go too high. So that's an important one. And then you also have to watch out when your body naturally makes steroids a certain level, and so we're kind of adding to that. And if your body has that extra, not from your body, steroids present, the ones that are natural tend to go down. So we have to be real cautious. If you've been on steroids for a period of time, you don't just want to stop all of a sudden because you can actually have your natural ones will be gone, and so you won't have any steroids. You kind of need them for function. So we always usually, if you've been on it for more than just a couple of days, we usually taper it down. That's gradually decrease your dose for a period of time. So if you've been on steroids, you probably had those kind of prescriptions where you're going down every few days on your dose. So that's something we always want to do with steroids. The other thing is with a lot of these agents that affect the immune system, there is an infection risk with it. So you're suppressing your immune system and it doesn't respond quite as well as it usually does. It will respond usually, just not quite to the same extent. So it's just a little bit of an increased risk there and something to be aware of. And when I do point out the infection risk, it's good to, some of those obvious things we know, like checking to see if your temperature is high, but you don't always have a temperature. But if you're, not feeling normal, feeling very drained, maybe a good idea to go to your doctor and they can actually do some blood tests and see if your infection and your inflammatory markers are really high. So. Then there's the immunomodulators. So these are, I'd say, compared to the agents we've talked about, the salicylates and the steroids, these are kind of stepping up the level of immune system suppression. Some of these are actually used in chemotherapies in some cases. Some of these agents like methotrexate and then tacrolimus is actually an agent that's used sometimes in people that have had transplants to actually calm the immune system down so it doesn't attack the transplant. So these agents can be used in different ways, but they do generally have a higher risk of infection with them and higher side effects. They also will affect a lot of your the idea with infecting the immune system here is they're rapidly dividing cells. And so you also get a lot of the other rapidly dividing cells, like your red blood cells, which can make you feel very weak and tired. We call that anemia. They can also affect your platelets, so you can increase your bleed risk. So you have to be real careful with these, and they'll keep a real close eye on you if you're on these agents. But they can be very effective at treating. And as we're kind of going down these treatment options, the effectiveness for non-responders to the earlier ones usually goes up. So they are beneficial for patients. And then these are, I guess, what I call kind of the newer, most exciting, unfortunately also the most expensive agents that we have to treat these diseases. These are the three, you usually hear them referred to by either the brand or generic name, but Cimzia, Humira, and then the Remicade. Those are the brand names, and then you can see the generic names. They'll have the mAb behind them because they're all actually antibody products. So that means they're actually a modified form of an antibody, like the antibodies that you naturally make to fight disease. So these agents can be quite expensive, as I mentioned. Sometimes in the neighborhood, if you don't have insurance, they can be in the neighborhood of $2,000 or $3,000 a month. So they can be very expensive. And so one of the things I'll talk about, if you don't have insurance, there are some programs that the drug companies offer that you can investigate, and they'll sometimes be able to help you and reduce that cost for you. And then if you do have insurance, there are also some things that can help with that too in terms of the cost. But they are unfortunately very expensive agents. I also do want to point out the Remicade, the top agent, is actually one that's usually given by an IV infusion. So you actually come in and actually have a bag, IV bag, intravenous bag, where they'll give that to you. The other two are given by a subcutaneous injection, so kind of like insulin. It's a simpler thing that can actually be done more easily in an office or at home in some cases. So that is an advantage. And they are not given every day, which is nice too. It's something that are usually done every few weeks. So that is a nice benefit of these agents, and that you don't have to necessarily do it every day. These agents actually target tumor necrosis factor. So that's actually an interesting factor. I think it was originally found when they were looking at cancer cells. So they were trying to find out what was this factor that was involved in causing cancer cells to cause breakdown and death of cells. And they discovered it, and it's really involved in a number of ways. And I can't go to explain all of these to you, but there's a number of inflammatory processes that it affects. It affects cells in a number of ways and can cause cell death. And sometimes when we get these ulcerations that occur in the GI tract, the tumor necrosis factor may be involved in that. So these biologic agents we have actually target that factor and try and remove it or remove its effects, so that you don't have as many of those problems that result from it. So as we said, this is an inflammatory, in some sense, an autoimmune disease. So if we can attack one of the potential pathways that's occurring and stop it, sometimes you can get improvements in your symptoms, and that's what these agents try and do. Just wanted to visually give you an idea. So an antibody generally looks like the one here on the right or the left. The one in the middle is actually just one of the fragments that they use. But these are the three agents that are out there. So they are antibodies like the ones that are present in your body. Like the reason we give vaccinations is to have antibodies present so you can respond to diseases. These antibodies, though, are targeted at that particular factor. So we're trying to remove very particular thing from your body and its effects. So that's what they're trying to do with these antibodies. So there are some what we call contraindications, things that you, in situations where you wouldn't want to use these agents. And I just wanted to point some of those out there. They do some testing usually before you start these agents. They test you for tuberculosis. They want to make sure you don't have tuberculosis, because if you did, a lot of times that can be what we call latent, and it can come and flare back up. So if you have tuberculosis or you have untreated tuberculosis, it can be one of those reasons we wouldn't want to use the medication. Also, if you had an active infection, that would not be a great idea, because it could have a greater effect on your body if you were on these agents. And then if you had an ulcer, non-healing, or hepatitis, those would be other reasons we generally wouldn't want to use this medication. I did mention the adverse effects, and they do unfortunately go up with these agents too. but not for everyone. I also want to point out when you see, you look at your drug or in this case, your injectable agent, and you see the list of adverse reactions that are present, it's usually a mile long and includes everything from itchy skin to death. And you're wondering, is this going to happen to me? Most of the time, these things don't happen these are just reported if someone in the studies, they usually study thousands of patients. And if even a couple people have this reaction, they have to put that on there. So a lot of those aren't going to happen to you, but there are some that are more common. So that's why I want to point out some of the serious ones or the more common ones. Injection site reaction doesn't sound too bad. You can get a little bit of redness around the site, and these kind of go from not so troublesome to maybe a little more serious. For the agent that's given by IV infusion, an infusion reaction can sometimes occur, and we can deal with that by slowing it down or giving some agents to prevent that before starting them. Vaccines, you don't respond as well. As I mentioned, this agent is kind of calming down the immune system, attacking the inflammatory pathways. Unfortunately, when we do that, you don't respond as well to vaccines. So a lot of times, if you're going to be started on one of these agents, we'll try and get you up to date with your vaccines beforehand, so you're all built up in terms of your immune system. Because afterwards, you don't do as well. And actually, some of the live vaccines might be a concern because you might have a problem of getting an infection with those. So you have to be real cautious about vaccines. Make sure they know you're on these agents before giving a vaccine. Infections, we already kind of talked about, but there's certainly a little higher rate of those, so that's something to be aware of and keep an eye on. Autoimmune disease, as we're kind of modifying that immune pathway, sometimes that can cause problems, but this is fortunately very rare, very, very rare. So that's a rare but serious one. Heart failure is a rare but serious one also. And then malignancy. So some forms of blood cancers actually have been potentially linked with these, but they're very low. So we're talking in the neighborhood of 1 in 10,000 kind of situation. So it's not a common thing by any means, but it's a serious enough thing that you want to be aware of it and understand that there is that risk. I did want to speak a little bit to patient assistance programs because those can be really important depending on your insurance status and how much these agents may cost you. And fortunately, these agents are nice in that they do have, I think they recognize that they're expensive. And so a lot of different assistance programs will actually have limits on your income. These actually don't specify a general income limit, and they sometimes even if you have insurance, you can do these. A lot of other assistance programs, if you have insurance, they won't do it. So you can investigate these. These may be helpful for you in some situations. I put this Needy Med site on there. This is a really helpful site that's out there. It's not any particular drug company in this case. It's a conglomeration, so of a bunch of different information. And it's actually not, I don't think it's actually funded by drug companies. It's actually just out there to try and help patients. So they have, for each of these agents, they'll have a little page about it. And if there's any coupons present or the discount programs, you can actually find it on there. So they'll have, if there's any income requirements for an agent, they'll have it on there. If there's any insurance requirements, they'll have it on there. And they usually have that application you can download. In some of the cases of these agents on this website, they actually just have a link to the company's webpage. But for a lot of agents, they actually have an application you can download. A lot of times it's a fairly simple application, usually a couple pages. You can fill out some, your doctor can fill out some of it. And then you can actually send it into them along with some, usually you have to kind of prove your income and things like that with a tax document or something. And then I did put some of the different actual names they have on for the different companies. If you go to the company website, you can find those there too. But I'd encourage you to take a look at these. Those are very helpful. The other thing I want to point out, since these are so expensive, a lot of insurance companies will have them kind of regulated, and they'll have to kind of prove your need. We call that usually a prior authorization. So if you go to look into these agents, a lot of times your physician can help you navigate that. And if there is a prior authorization, they can either switch it to the one that your insurance company prefers, because a lot of times for those 3 agents, there's not a lot of data outside of specific patients that the one is a whole lot better than others. So a lot of times it's based off maybe what your insurance prefers or what your physician prefers. Sometimes they can switch you to one of the other ones. And then also, if you failed one of them and it's not working well and you go to try another one, you sometimes have to document that, and then your insurance company will usually let you try the other one. So just wanted to point that out because that can be really an important aspect for patients as you're navigating those. So that's pretty much the end of my presentation. Thank you. I think we'll take some questions here from you. So if anyone has questions for Dr. Mattal or myself, we'd be happy to try and address them now.
I wound up here at the emergency room a couple weeks before Easter with a twisted bowel. Okay, what causes it? How can you prevent it? What's the chances of it happening again?
All right. Hi. This a little bit different from the topic, but twisted bowel is also called as volvulus or what torsion or why does it happen? We don't know a whole lot about it. It's just the intestine is hung in the gut with a mesentery, which is like a little kind of flap, and sometimes it gets too long, or some people are born that way. When it happens in infants or young kids, tend to do surgery and fix it. Someone on an adult population, sometimes it just happens once and doesn't happen any more time. But if it happens repeatedly, then a surgery can be done and the flap can be shortened or the gut can be fixed so that it doesn't move around. It's kind of like having a garden hose moving around, and it can turn and flip all the ways around. So that we just fix it so that it doesn't get turned on itself. So hopefully it won't happen again, but if it happens repeatedly, then surgery can be done to avoid it getting twisted. There's not a whole lot you can do. Hopefully it won't happen. But if it does, then I guess surgeon will have to fix it. Yes, ma'am.
What's the main difference between irritable bowel syndrome and these two?
Yes. So, I was expecting this question. Yes, the question is, what's the difference between irritable bowel syndrome, or IBS, and inflammatory bowel disease, or IBD? Well, to begin with, irritable bowel syndrome, it's a misnomer. It's not really irritable. It's more like sensitive bowel syndrome. So there's the things we just talked about, all the inflammation, and this is more like First of all, I'll talk about inflammatory bowel disease. It's an autoimmune disease where the gut is getting affected by all these hyped up immune activity and causing all the damage and almost like an innocent bystander effect. Versus in irritable bowel syndrome, the gut is just too sensitive. Every small effect on it, for example, stress or certain foods or just by itself, it's hyperactive and it doesn't behave the way it should. People can have diarrhea, constipation, pain, just generalized anxiety in the gut. That's how I usually perceive it. So it's very different, and the treatment is extremely different. Over here we're toning down the immune system, while in irritable bowel syndrome we try to soothe down the nervous system of the gut by either psychological therapy, by cutting down the factors which are leading to this disease, or by giving more soothing things like fiber, taking care of the acute episodes with medicines which cut down the spasms, like anticholinergics, which are usually affecting the gut. So it's very different and doesn't have any of these sequelae, the complications of irritable bowel. Irritable bowel syndrome is a lot benign. It's more just doesn't, people don't like it, but it doesn't causes all these things which we just talked about, all the complications and the bad effects. And unfortunately, we can treat inflammatory bowel disease a lot more better than irritable bowel syndrome. Anything you want to add, Mike? No. Yeah. Yes, ma'am.
I have a question. I don't know if you can answer or not. When I go out walking, I've had one of the problems. I have irritable bowel syndrome.
I'm sorry. When
I'm going out walking, I've lost control of my bowels. Even though I've gone before I left the home, I'd be walking and all of a sudden I can't control anything.
Right.
Is there anything that I could do to change that?
Sure. So first of all, the question is, some people have this diarrhea, or they even go to the toilet and they feel like they have to again go, and it's usually loose or watery. Usually it can be loose or watery. So first of all, we have to make sure there's nothing else going on. First of all, we have to make sure there are no infections going on, if there's no parasites or worms and all that, which can be easily taken care of by looking at a stool specimen, making sure there are no worms or eggs or parasites in there. Following that, if that's negative, a condition which is much more common in older population, in their 60s, 70s, especially in females, is something called microscopic colitis. Sounds similar to ulcerative colitis, but it's very different. Doesn't have all this complication. It's also sort of autoimmune disease, but doesn't cause as bad of a colitis as ulcerative colitis. If that's the case, then we cut down the immune system by giving different medicine. If that disease is not going on, then we think more, although there are some other more rare conditions, but then we tend to think more of irritable bowel syndrome with diarrhea predominance. And then we have certain medicines to cut down it, or we can even give Imodium, or more in social situations, increasing the fiber which can absorb all the water so that it's more solid stool versus watery stool. Certain medicine which slow down the transit of the gut, those can be given. So I think increasing fiber in the diet is something which is very easy to do, very benign to do. That's something we can start with. If it keeps on happening, then we can go higher, more aggressive testing to find out what's going on. Yes, ma'am.
So is there research around Crohn's disease and when it presents? Like, I'm
Yes.
aware that oftentimes it's in adolescence,
Right.
but if it's diagnosed at a later age, does it evolve differently or?
Right. So the question is, when is the Crohn's disease usually diagnosed? Is it only in adolescence or later? And how does the disease course different if it's diagnosed later versus early? Well, so there's what we call a bimodal distribution of inflammatory bowel disease. It's seen in young people in their second decades, which are teenagers, and then in their later decades. So the graph kind of goes a very low chance, then high chance, then again goes down in their 30s, 40s, 50s, then again in 60s and 70s it goes up. So two peaks. But again, it can be seen, as I said, in pretty much every population. I have diagnosed patients in their 20s, 30s, 40s, 50s. So how does the disease differ? Well, the longer the disease course, there's a lot more complications. For example, the cancer risk is high after 30, 40 years. We talk about all those things because people who are diagnosed are in their teen years, and when they turn 40, 50, which is kind of prime of their age, that's when they tend to develop these diseases. People who are diagnosed later in the age, they tend to develop lesser complications. They are much more easier to control compared to teenagers or younger population. So any age group can be diagnosed with Crohn's or ulcerative colitis, and the disease course actually is much more aggressive in people who are diagnosed early versus in later age group.
So some of the statistics where it talks about 40% of people with Crohn's with fistulas, is that's kind of taking all of those?
All of those, yes. I think younger population who gets diagnosed much earlier, a lot more higher, almost 90%, 80, 90% tend to develop these complications. Most of them, my patients who were diagnosed in their teen years, they usually have a couple of surgeries of Crohn's disease, versus older population who I can actually manage with as Mike mentioned, very simple medicines, which don't have a whole lot of side effect without surgeries or needing biologic therapy. So younger population tends to, and their immune system tends to be a lot more aggressive also. So we have to remember this is an autoimmune disease. The body itself is attacking the body, and younger people tend to have a lot more immune system, which is jacked up, and then that causes all the damage. Any more questions?
And actually, could you speak to that same issue in terms of drugs and treatment? And I'm someone who was diagnosed in like 56, and I was on Remicade, but ended up with drug-induced lupus, and so I'm just trying to think of
Right.
where the difference is. It's hard to find research that's that specific.
Right.
Yeah, unfortunately, I don't, in terms of, the question is kind of in terms of the later diagnosis and the treatment course, is there maybe particular research looking at different agents? Unfortunately, a lot of the research that's done is to prove that the drug is effective at treating it versus necessarily differentiating little subgroups of patients and what the best option is for them. So unfortunately, when they do those studies, they're very small, and there's not as many that I'm aware of, unfortunately. So it's more of a trial and error thing where you can kind of move on to different therapies and find what works best for you. Unfortunately, there's not a lot of studies to show ahead of time. You sort of have to find that with your physician.
Yeah, and talking about this, Mike presented a very good slide, which was top-down and step-up therapy. So it was actually a few years ago, maybe 5 years ago, the top-down therapy was in vogue, where probably a lot of it was the drug companies' push that why don't we just give biologics and just take care of everything rather than giving something very, very less effective, then going on a higher, then going on a higher. Why make the patient suffer all this? Just give the big guns right away. But then and actually the results were good at 26 weeks when people were in great shape. But with time, the effect goes down, and at like 52 weeks, then they end up getting similar. People will be on similar sort of therapy at 52 weeks, and the cost was a lot higher in the biologic arm versus the other arm. And the side effects, someone developing lupus because of this treatment is a very major side effect, and I think things like those were not really appreciated. Another thing which can happen is lymphoma with this biologic therapy, which is extremely uncommon, but someone in their teen years or in their 20s developing a lymphoma, which is pretty much always fatal, is something which we were not prepared for. So now at least me and most of my colleagues have this step-up therapy. When we start with a simpler therapy, almost 50 to 70% patients are able to be managed with 5-ASA, which is a drug which is quite safe drug, has some side effects but not as bad. Then going higher, azathioprine and 6-MP, 6-mercaptopurine, which are drugs which we use when someone is on steroids for a long time to prevent the effects of steroids, is beneficial because then we don't have to give prednisone. And they have been there for 20, 30, 40 years with some side effects, and they can be easily monitored. And then going into biologic therapy. I mean, biologic therapies are great, but has its own risks. So, all right. Thank you, everyone. We'll have a 10-minute break, and then we'll have the most interesting things, the nutrition, the foods, the probiotics, all those things, and then the psychological aspects, which I feel are very important in this disease, talked by Dr. Carrasco and Nancy, our nutritionist. Thank you very much.
You're watching City Channel 4. On TV, online, on demand, on Facebook, and now on the go on your mobile device.